Welcome back to another episode of Thanks for the Consult. Uh, as usual, today we have with us Aaron. He's not going to wave or say hi, I guess. Hello, Aaron. Today's guest we have with us is Chief Eric Schmidt. How are you doing?
Doing good. Looking forward to talking today.
Absolutely. We're looking forward to talking with you. So that works.
Indeed.
um, so I know you, obviously. Yes, it's not obvious, but I know you. I believe this is probably the first time you've met Aaron, if not maybe once or twice up on the mountain. But tell us a little bit about yourself, so the folks listening at home can understand who you are.
All right. Well, I've been doing this a bit, like 43 years in EMS. I've done it primarily in Pittsburgh, but also on the other side of the state, around the Philadelphia region, in those 43 years. Um, every type of service you can imagine, volunteered, for-profit paid, non-profit, fire-based, air medical-based, done a little bit of everything.
So,
Been
what haven't you done?
Well, I'm sure there's a long list of those things. But in EMS, I've done a lot of them, for sure. It's been a passion of mine for a long, long time. I've been here at Shader-Hampton for 6 years, and I said many, many times that the best job I ever had was when I was with Penn Star Flight in Philadelphia, and that was until I got here. It's been an amazing environment, amazing communities, a great board of directors that supports me, and it's been a game changer for me. It's not how I expected to finish my career, but I'm very thankful that's how it turned out to be.
Awesome.
And I feel the other things I'm involved in, I think they're germane, probably as our conversation is going to go today. This is my paid gig, but it's pretty cool to get up every day and go to work and to get paid for it, something that I love doing. But because of that, I've really gotten involved in a lot of things to try to help EMS gain the prominence that it deserves and to educate people about the role of EMS. I'm the chair of the Allegheny County EMS Chiefs Association, which is part of the Allegheny County EMS Council. I am an elected board member of the Ambulance Association of Pennsylvania. I'm on the executive board for EMS West. And I also am part of a group and a grassroots advocacy group called Citizen Concern for EMS, or cc4ems.org is our website. And that's a group of mostly retired EMS providers, chiefs, physicians, educators. And I'm the principal for that group. The primary goal of ours is really to educate municipal officials to EMS. The importance of EMS, the service we provide, the funding crisis that EMS faces, and frankly, how to evaluate whether the EMS service they have is good.
Yeah.
We think that's a very significant issue because there's certainly varying levels of quality out there.
Absolutely. So as people know, I've been doing this for a while. Aaron, been doing a little bit, but like you, I spent a lot of my time in Pittsburgh, and I can say that you run one of the better EMS agencies that I've had the pleasure of working with, for, and around in my 22 years of doing this. So, firstly, let me just say, keep up the good work. I think that
People here make it easy, and that's the root of what we do.
maybe I'll have a chat with some of them, see if we can't make it a little more difficult for you.
We try at times, no doubt about it.
I feel like I missed a memo on like the cool glasses situation going on. Like you guys just look so educated and professional.
Well, yeah,
That's
just
you're trying to look like an
older.
You're really not.
Just for the job you want.
I shaved a little bit because it was getting really gray, and I was getting depressed every morning.
Understood.
So you've been busy, it seems. Obviously, running a service is certainly a full-time job, and it sounds like you have several other full-time jobs for which you're not paid
Yeah,
on the side.
this is true. This is true.
Obviously, EMS is something that we're all passionate about, so we absolutely appreciate all the work you're doing in the background there for trying to keep EMS funded and funded appropriately. I know that I've been to a class of yours. I know you're doing it again. Once this episode airs, it'll just happened, but it really eye-opening about the way EMS is funded, or I guess underfunded in most cases. But and I know that's something you're passionate about. Anything on that you'd like to kind of share with us?
Well, boy, man, as you know, I have a whole talk on it and actually several whole talks on it. But, I think there's some public perceptions out there that just aren't factual. From municipal leaders' perspective, I think that they view it as, well, we bill insurance, so we don't have to have any issues. We must be sound financially. From an employee's perspective, they're like, why can't I get paid more? Why don't I have better equipment? Why don't I have this? Why don't I have that? And, the bottom line is that the system, the way it's designed in EMS is you don't transport a patient, you don't get paid. If you do transport a patient, looking at our specific numbers for Shaler Hampton EMS, 88% of the time that we transport a patient, we're reimbursed less than the cost of providing the service.
Yeah, I definitely don't think that's public knowledge that most of these places at best are running at a 8 or 12% deficit at best.
Yeah, we're not unusual in that. There's certainly places that are better off, and there's a whole bunch of places that are not as well off. But everybody's primary provider or primary payer is Medicare, and Medicare pays well below the cost of providing EMS service. So for us, that's 62% of the time we respond for Medicare patients. And Medicare is another great thing, that with Medicare managed care plans, the patient actually pays more for the ambulance service than Medicare does these days. So
That's absurd.
the Medicare is paying a couple $100, and the patient's paying like $270, and our cost to provide the service is $558. So the math just doesn't work.
No. So obviously, in order to keep the lights on, the trucks working, people coming back to work, you got to make that up somewhere. I know a lot of places do the membership drives, different donation drives, but I'd imagine in today's kind of economy that becomes more difficult. People are willing to take a gamble on their health more than they would have in the past, I guess.
Right, and then the payback on that is less. We're just in the final stage of kind of wrapping up our subscription drive for the year. For a long time, the subscription drive here until 6 years ago was you subscribed and you had no out-of-pocket expense. We couldn't do that anymore because the insurance companies raised the co-pays and deductibles and all those kind of things. So in essence, you're losing money on it. Right now, we're at about 29% across the board of people that participate in the subscription drive. For me, though, that means 71% of people don't. And the money we take in from that, we give a fair amount of it back in discounts for people when we take them as patients because they get half off their out-of-pocket expense.
Okay.
So, the money that comes in is not all that it seems, but it certainly is a significant help to us.
Yeah. Now this might just be my ignorance on the matter, but 29% actually sounds high to me.
It is. It is high,
Okay.
actually. Yeah, that's the good news and the depressing news all in one.
Okay.
We're happy that it's that high, and it's higher than many, many services enjoy. But it's, and we appreciate support from people that do, but it's a pretty dismally low number.
Yeah.
Far below half, and we're here 100% of the time for 100% of the people.
Absolutely. Absolutely. So what besides obviously the subscription drive and the billing and whatnot, what are some ways that you're combating the deficit that you would otherwise be operating completely negative and
Yeah.
can't be around very long?
Yeah, the game changer for us is absolutely the support we get from our communities.
Mhm.
We service Etna, Hampton, and Shaler.
Mhm.
All three of those communities contribute to our capital needs every year and our operational needs every year.
Yeah.
In addition, they provide us a lot of services, and that we fund about 90% of our own budget. What we get from the communities accounts for about 10% of it. And,
Okay.
I always hesitate to give these kind of comparisons because who's our most important partners? It's the police departments, it's the fire departments. We all work so closely with all of them. But, if you look at when municipalities, not mine, mine give us support, municipalities that don't support their EMS agency, but put $1 million or $2 million into a police department.
Yeah.
Adequately fund EMS would cost so much less than that to give you a
Mhm.
thriving EMS agency.
No, I agree.
The change doesn't happen until there's crisis, of some sort. And unfortunately, many times that is a very bad outcome for a significant patient or a very well highlighted call, something along those lines.
Yeah. No, I agree. And it one of the things I've noticed, just I guess observationally, is that the services that seem to be, as I call it, responsibly staffed, like you're staffed to handle your boroughs, right? more often than not end up looking understaffed because they're out of town helping another service that may not be staffed up to the correct staffing level for their coverage area, and it creates a snowball effect. So if you go to the town to the south of you, then the town to the north of you has to send their ambulance into your town to pick up your call, and then the next town, and then at some point the chain runs out, and it's you can't send the one furthest south, furthest north to cover that call because that's and
It's a game. I mean,
yeah
we are in Allegheny County now, 32 EMS agencies. When I started, being a long time ago, that number was 130 plus.
wow
Every community, there's only 130 municipalities in Allegheny counties. It really was more than one per community in some cases.
yeah
Here in Shaler, there were 3 ambulance services,
yeah
at one time. So that number's come down. It's at 32. It's probably a better number in some places that, different. It's amazing to me how different regions of the county work differently. We're all the same 911 center, but East is different than the West, different than the North, different than the South, different than the city,
oh yeah
And it's same for the regions, and the challenges they have and the successes they have are different.
yeah it's great. So I worked a while out in the east zone of Allegheny County, and we operated primarily in the east zone, but we would cover calls in the north zone and into central, which is Pittsburgh.
Right.
And each channel, everything was different. The way that they wanted you to identify certain things was different. Like if I get on North EMS and I say, county, send me a car, they're not going to know what the heck I'm asking.
Right.
But if I do that in the east zone, I'm going to have every available police officer heading my way
Right.
very quickly. So it's just, and it's, part of, you're probably from your furthest point to the closest point, maybe 5 minutes from an east zone, and it's in that 5 minutes, so much changes.
Yep.
It's,
crossing those lines, it's good. Crossing bridges, crossing quadrants in dispatch zones absolutely changes everything.
Yeah, and then in the city zone, I don't even know what they want. So I
Eric,
was always getting yelled at.
Why do you think it's such a hard sell itself, or for politicians to actually get monetary reimbursement for your local EMS agencies? I mean, people will do it for law enforcement, for fire, and they don't really think about it. I think if you ask people on the street, you'd be like, "Oh yeah, we should support like they assume that's already happening."
They do. You're absolutely correct, Aaron, and I think that that's part of it. The talk that Fior referenced is called Canadian Dam Raise, and it's all about educating EMS providers why they can't get that raise, what the finances are behind EMS, but also what they can do to be an advocate for themselves and for EMS, because it's a force multiplier, right? There's 32 EMS agencies in Allegheny County, so there's 32 EMS chiefs, but there's 3,000 EMS providers. And if they all have information, all know, somebody knows the elected officials, somebody knows the mayor, somebody knows the president of council, their family members, my family members, don't necessarily understand EMS like they should have, or they should, and understand how it's funded or not funded and what the needs are. So, we have to be the people, we being you, Fior, me, all of our colleagues, have to talk to the people we know and talk about the challenge and talk about how real they are. We've been kind of saying for years we're going to have problems, there's going to be collapses. Well, there are collapses.
Yeah.
There's ambulance services closing pretty regularly. Another issue we face right now is the Pennsylvania State Department of Health, Bureau of EMS, hasn't provided any EMS data since 2021. So for the last 4 years, how many ambulance services closed? Don't know. How many paramedics and EMTs have we lost? We don't know. You look at national studies and they don't have accurate data on Pennsylvania because we haven't produced it for 4 years. So, all these things we need, these tools we need to make decisions and understand the problem and try to get it fixed. We don't necessarily have availability to. And then Pennsylvania, boy, we love tradition, 250 years of history competed by progress, and it makes it harder when you have 130 municipalities. We're different than other places that have county-based, or larger geographic-based services.
Yeah.
So it makes the message harder to get out.
Well, do you think that's intentional obfuscation from the state of Pennsylvania not putting out those numbers? Because I can't imagine that data would be hard to rally up.
I don't want to believe that. Although it's hard not to have some buy-in with, given time, and we've made that, that need known. The current director, Anthony Martin, is a really good guy. He comes from a strong U.S. background. Still newer in the job, so I hope we're going to get there. It's numbers we really need, and I hope that we're going to get that data available. So,
Yeah. I
uh,
mean, Pennsylvania, there's two things we hate. It's the way things are and change.
yeah,
So,
very true.
I mean, I imagine that's the same out where you're at. Aaron, you have what, two? Well, you have two paid services in your county, correct?
Right. And then I think 5 volunteer.
Okay. Yeah. So often those calls in the middle of the night, I imagine the volunteer services aren't picking those up as
Yeah, I think it's
frequently, or
10,000 square
daylight
miles,
calls.
and we have 2 ALS trucks overnight to cover about 10,000
Yeah,
square
crazy.
miles.
Yeah.
Yeah, there's times where I drive an hour just to get on scene of a call.
Yeah.
And we talk about, we talk about the issues we have here in Allegheny County. We're, urban and suburban county, very much so. And the problems we have are real, but they're nothing in comparison to rural EMS and rural Ohio and, wherever you are. The more rural, the worse it is, without a doubt.
Yeah.
Where you don't have an agency in the county, people coming from great distances away. And there's without a doubt a loss of life because of those things.
So how do you, as a chief, balance the getting the latest and greatest equipment that will help save lives and ensuring that you're paying enough that people want to work there? How do you, at some point, you have to justify, hey, this is an amazing tool and it may help, but
Mhm.
without the provider, it's nothing. So how do you kind of do that? How do you balance? Because obviously there's got to be some budget balancing, that some tightrope walking, I'd imagine.
So
Um,
when I got, I literally had to make a phone call at our first payroll to one of the municipalities and say, I need some money to meet payroll. The situation was that bad financially, and we had to do that. We are far, far, far away from that now. What
yeah,
my biggest concern coming here, my previous role is with Allegheny Health Network and the pre-hospital lifelike program. So I visited EMS services all over Western Pennsylvania, the Panhandle of West Virginia, Eastern Ohio. And I saw really good EMS and some decent EMS and some really bad EMS. There's some common things there that led to that. Rarely was it the street level provider that caused problems. It was leadership, being management, or it was the board, or both.
yeah,
So when I came here, I was incredibly focused on the board. My first 2 interviews were about them, not the organization. What did they want to do?
yeah,
What were their frustrations? What problems were they trying to fix by hiring a new director?
yeah.
All those kind of things. To my good fortune, everything they told me that day was true. They've
That's
helped
awesome.
what they said they would do. They have not done things they said they wouldn't do. And we built a trust. Just last night was a great example. A bunch of my staff doesn't even know this yet if they're not working today, but we had a board meeting last night. We have a capital plan for replacing ambulances and so forth. And we had our 5th out ambulance that we did not plan to replace. Has relatively low miles, although it's 8 years old. We thought it was going to be reliable, be able to use the 5th out ambulance and so forth. And it's just not. The last 6 times we put it in service, it broke.
Yeah,
So outside of budget and outside expectations, we're going to need another ambulance. We talked about it last night. It was a long discussion, lots of questions.
mm-hmm.
But in the end, they trust that I'm going to bring them accurate data and what our needs really are.
Yeah,
Fortunately, we're in a much, much better financial situation than we were 6 years ago. And,
yeah,
we're there because of many, many things, but it all comes down to cooperation.
mm-hmm.
Elected officials, my board is almost all elected officials from the 3 communities.
Okay.
I attend every municipal meeting every month, provide data, answer questions, talk about updates,
Uh,
and keeping people. There's people that have been here since the time I walked in the door, and there's some people that left because they didn't like the pay rates at those times. And we were painting a picture where we're going to get to. And we've gotten there. We've very significantly increased pay rates here. We have great benefits.
yeah,
We have great equipment. It took time to get all that stuff done. So those people that stayed for the ride and are still here today, man, I appreciate them all. And the people that
yeah,
have joined us in that time, I'm glad they're here, and we're doing everything we can to make this a place where you come for a career, not for a year or two.
Where do you
yeah.
think the sweet spot is for a board of directors and as far as their involvement with the service? Because there's some boards that I've experienced where they kind of sit back and don't do a whole lot. Maybe there's 1 or 2 members who are really involved, and then everybody else is just kind of like, sure, sounds good at their monthly meeting. Or you have people who are hyper involved with the service to the point where it's actually debilitating because they want to try to, make decisions that should maybe be a director role. Like, how do you balance all that? And since the board's kind of a self-appointed thing, how do you get a board of quality people that are valuable to an EMS service?
Also, in my circumstance, the board is actually appointed by the community that I serve. This organization has zero say in it, right? So The elected officials in 3 communities make the appointments, and there's an agreement we have with a formula of how many there are and so forth. And also uniquely, I'll tell you, there's 2 different things that are unique about our board. One is that all 3 police chiefs are members of the board, non-voting, but they're there, and they're those guys don't talk off, but when they do, people listen. We work together a lot, so they know our service, and we know them. And the other thing is that we have by our bylaws, a required board certified emergency medicine physician. And that's a different perspective. We start talking about clinical issues. People in the room, for the most part, aren't clinical. So when it's Dr. Martin Gill, when he talks, they definitely listen.
Yeah.
And when he talks about the experience receiving patients from us and his EDs, that's beyond valid, to say the least.
Yeah.
So, and what's the sweet spot? I'll tell you that I talked to the president of my board, who's, they're all my boss, but he's my most direct boss. I talk to him maybe once a month outside of board meetings. I talk to the rest of them mostly at the board meetings.
Yeah.
They are not involved in operations, and this is going to sound arrogant. I certainly mean to be that. But if I'm the guy in this chair, whoever it is doing their job, the board shouldn't have to be involved in day-to-day operations. That's not their function. Their function is to make sure that I provide the education they know what we need, and they find the means to provide it and to hold us accountable and make sure what we're asking for is realistic and needed.
One of the things you said, I don't know if you realize it or not, but it kind of stuck
Oh,
with
no,
me,
I know.
is the ask questions, and you ask questions, and everybody's asking the questions. There's a communication, a dialogue. Like you said, it might be, I'm sure at the beginning it was far more frequently than once or twice a month. All right. As you kind of get like, okay, we can trust this guy. What he's telling us is accurate data. Where he's going is where he's going. And vice versa. But that communication becomes, I think, key to, and I've said this, I've worked for some organizations where, it seems like if the board could get out of its own way, they'd be doing a heck of a lot better than they are. And it seems like if you have people, if you have a director or a manager or a paramedic or an EMT or whatever you have them in that position, if you do not trust them to do their job, get them out of that position. To me, it's as simple as that. If I'm the president of your board and I don't trust you to run the service, I'm getting rid of you. You know what I mean? It just, otherwise, everybody's spending more time chasing each other's tails and nobody's actually doing what needs to be done to keep the service not only just afloat, but growing and providing care to the patients and the communities that we serve. So,
Yeah.
but I
We
think
have a common
communication.
friend that asked a question at the presentation I did up at Seven Springs, and that was, what are the qualifications you want for somebody in your position? And, I'm a very lucky and unique position or person in this position. I don't have a college degree, but I had great mentors through my entire career that helped me get to where I am and give me the tools and the understanding I needed to have. To be in this chair, a chief, a director, whatever your title is, your organization, you have to not only. I'm not the best paramedic here. I'm a decent paramedic. I'm not near as good as I used to be. We have some real kick-ass paramedics here, and I'm not them. But I know what our numbers mean. I know what our business practices are and need to be, and I know how to translate that information to our elected officials and my board directors. And I can't tell you, I'm maybe not the best paramedic, but I know a great one when I see one. And we work actively to recruit those people here. Our staff is amazing as mentors, and when we have students here, EMTs or paramedics, which we have a boatload. Treating them well, and we can learn so much more about those people in that process than we ever could in a 1-hour interview. Many people that we have here came and did clinical time here, liked the service, liked the way they were treated, and liked the input, and say they hear from our staff, and they stay with us.
Yeah. I'll be honest. I send students to you all the time. Like, hey, where would be a good place to go? I'm like, Shaler Hampton. They get a decent number of calls, which is obviously important in the student world, right? You don't want to sit there for 16 hours and run one call.
Or run all night, not do anything, right, Fior?
I mean, well,
That was not
sometimes
right here.
you need a nap, for those of you that haven't picked up on it, I work part-time for, for Eric there. But yeah, no, I mean, and, but you have a good mix of calls. And you don't, there's nobody there that I would, if they were like, "Hey, I'm going to go precept, who should I avoid?" That list doesn't exist. Whereas, certain places, we certainly have a list of like, maybe steer away from this person or that person. I mean, I'm lucky enough to know some of the personalities of the different medics that are there, so I'm able to kind of be like, "Hey, you would do really well with this person because I think they'd be able to help you in a way that would be good for you." But I never feel like if
To see that
somebody's,
list someday.
well, you're gonna need a scalpel. But yeah, but I'm never like, I wouldn't go there. I'm always, anytime they ask for a service in the North Hills, you're one of the first that comes up.
Oh, I
Uh,
appreciate that.
but
Eric, I do have another
yeah,
question if I may, if you were.
you
Please.
may.
So I was just curious, as your perspective is, how you think it would be the best way to go about addressing this. In the more rural areas, it seems to be a pattern where you'll have a couple larger ALS services that are staffed about as minimally as they can be to still be able to keep an ALS service, and licensure. Um, and you'll have like one or two, and they'll be absolutely rivals with each other, like trying to take each other's calls, constantly undermining each other. And anytime, and I can think of this as the case in about 3 counties around me. Um, Anytime that you have these two services, talking about, let's go to the municipalities and see if we can get some financial support, the immediate reaction is, well, if we do that, then the other service is going to say, well, we'll come in and do it for free and run you out of business. And it doesn't matter if you can't do it good because they're going to do it for free. So how do you like navigate that? If you have any thoughts about how to actually get a service to a point where they could do that and work together rather than undermine each other.
Can I interject a question real quick here?
Question for the question? Sure.
Yeah. Um, if the service is concerned about another service more than the patients they service, how are they servicing their patients?
Right.
So I think, Aaron, to come back to your question, and just like the different sectors of Allegheny County are different, Ohio and Pennsylvania are so vastly different EMS, it's unbelievable. But I think there's some similarities. Number one is just because a company is for profit doesn't mean they don't deserve public support. But just like a not-for-profit, just like a fire base, just like anybody, if you expect public support, you better be transparent, bring your books, be willing to open them, answer questions, and regularly provide reports about your status. There are some around here, especially in north of here in rural PA, there are some for-profit providers. They're the only providers in the county, 2, 3, 4 of them in an entire county that are doing a bang-up job for decades, and now they're hurting. They're like, well, you're for-profit, we can't give you money. That simply is not true. There is no stipulation in the law in Pennsylvania that stipulates for-profit, not-for-profit, fire-based, any of those kind of things. If they are doing the job and they're willing to open the books and show the need, then they deserve it. I don't care what their status is as far as for-profit, not-for-profit. So that's part of the question. The other thing I think that maybe is different in Pennsylvania, this is different by county, but certainly in Allegheny County and in most counties around here, the municipality designates who the provider is. So there's none of this warring, racing to scenes, or mother jugs and speed kind of stuff. It doesn't happen because somebody's designated for that area. So that's who serves that area. If they're not available, then CAD goes the next due and next, who hopefully is the next closest available. Around here you can designate anybody, and for the most part, people do designate the next closest available provider, and as it should be in my estimation. But
Yeah.
so I think it'll eliminate some of that. But I think, and the other thing is, we get along with all the services around us. Some we have tighter relationships than others. We train together and those kind of things. But we're here as a public service, and we support each other. We go in other communities. Sometimes they come into ours. That's just reality. Is it anywhere that is? You just can't cover 100% of your calls, but certainly we're hopefully covering a very high percent, and we are. We cover this. We provide much more mutually than we receive, and I'm pretty happy about that.
Have you had to go in and have discussions with other services about like, hey, let's, stop creating issues for each other? Or have you just always had a pretty amicable relationship with the services around you?
I came in a different perspective because I just knew all the services. I really did. It was a part of the nature of what I did before I came here. And I'm a really upfront person. Some people don't like that. I prefer it. It's how I am. I prefer how people treat me. So if you have a problem, with me, I hope you're going to come to me about it. If I have a problem with you, I'm definitely going to come to you about it. We're going to talk about it. Maybe we'll agree. Maybe we'll make things better. Maybe we'll agree to disagree. but we're going to talk about it.
Right.
Yeah.
That works pretty well for me.
Yeah. I think that one of the things that I think not just I think any little local microcosm, this will hold true, but that you have a ton of different services that it would benefit them to combine, merge, you know. Um, and this happens in the volunteer fire world. It happens in, EMS, every aspect of the world, I think. But people are afraid to lose their little piece of the kingdom, I guess. And I think what I've noticed is the organizations that are putting the patients first, where it's like, I don't know how we're going to pay for this, but we're going to make sure these patients get what they need. Those are the ones that seem to be doing the best, I guess, if you will, financially, because people want to support that. I think naturally people want to support an organization that is out in the community doing the things that they want them to do. Um, and I know this is something that most truck level providers hate, but PR details,
Yeah.
I think they're a necessary thing.
They're
If the
critically important.
community can't see
Absolutely.
you,
Yep.
and you tell me, hey, we're raising taxes or we're doing this to support our EMS, and you're like, I never see them. They're not doing anything, But you're out at the community events and the what have you, the football games, the concerts in the parks, the whatever it is. That's I think it's critical that the community sees you, but also not forsaking patient care for that purpose. And I genuinely mean this. I think you've struck a very good balance with that. So
We try.
yeah.
For sure. It is. I mean, I agree. There's great value in that. You have to be there. We are a community asset, and we've got to be upfront and open, and be out there so people can learn about us and meet our crews. It's great to know somebody before they darken your door.
Yeah, yeah.
Eric,
And at the end of the day, let me see what I'm paying for.
Eric, what do you think the toughest part of your job is?
Me dealing with me.
You know, that's a fair question. I'm a strange guy. I literally get up every morning. I love coming to work. I have so few bad days here. Uh, you know, it's this place just works. And it's a combination of a bunch of things. It's the people that are here. We are fully staffed. We have been fully staffed. We hire occasionally here and there. I have some people that are part-time staff here that have wanted full-time positions for a couple of years. We haven't had any openings. And certainly that makes my job easier. I, I don't know what makes a bad day. If things don't go, we don't have a great day here with motivation and people wanting to do the right thing and getting out the door and keeping trucks clean. You add that all up, it's almost nothing. It really isn't. So the things that might make a bad day for me are a little bit irritating, or however you want to put it. Uh, when you register on other people's scales, I just think it's a very fortunate set of circumstances here among all the moving parts of what makes a good EMS agency. And so I don't have many bad days.
That's awesome.
Yeah. That's just the truth.
So you said
Yeah,
that you didn't have, you said you don't have a degree.
Mhm.
Did you have much leadership experience in EMS before you took over your role as chief?
I did. I was manager with pre-hospital at AHN, and I ran their business development team. I was chief of the community ambulance service where I grew up for 15 years as a volunteer. I managed other places and projects. I was involved years ago when I was the pre-hospital manager at Mercy Hospital. When the FBI came knocking on our door after they raided a local for-profit ambulance service and asked us to run it for them. Uh,
Wow.
so, yeah.
that
So,
would probably make a bad day for a service director.
uh, most of we did for those folks, no doubt about it. So, yeah, I definitely had management experience before I got here.
Okay, because one thing I noticed is that a lot of times, they'll look for a new position for a chief or something like that, and it's a lot of times just one of the paramedics that's been around for a while, and then they start trying to run the service, and really, when you've just been a line medic for however many years, you don't, that doesn't necessarily mean you know how to run things from a business perspective. So I was just curious, if that was something that was a struggle for you whenever you started taking leadership roles, or if the time span in which, you kind of worked your way up made it that you were very familiar with that whenever you did.
It's a constant learning situation, no doubt about it. Probably one of the things that I struggle with the most is, I want to have a good relationship with everybody. Frankly, at the end of the day, we can go out and have a beer, whatever the case might be. But at that same time, if we go out and have a beer tonight, you might be somebody that I have to have a serious conversation with tomorrow. I hate that part of the job.
Yeah.
Reality. So that's probably one of the worst parts, but it's, not a real frequent thing. You talk about somebody being promoted from the role of paramedic to supervisor to chief, or whatever, it is not, I believe that to be in this position, you have to have good clinical knowledge to be able to recognize what a good paramedic is, what a good EMT is. But you have to today know the business side of this. You must, not only to evaluate your billing. We have a billing company that does our work. We're fortunate that we have an amazing billing company these days. It's just doing great work for us. And it's a great resource for us with questions and those kind of things. But you have to know the business side of how long your ambulance is going to last. What do they cost? What are the cost of equipment? What are we going to do when things go up crazy priced? We've been on a goal of standardizing our ambulance. 2021, we took delivery of 2 new ambulances. 2024, December 2024, 2 other new ambulances that are almost identical to the ones bought 3 years ago. A few very minor tweaks, and that's the way we're heading. But the cost difference between those 2 ambulances in those 3 years was almost $100,000 each. How do you cover those cost differences? We need new cardiac monitors. We want new cardiac monitors. There's a couple of them that are LifePak 15 Series 1s. If they break, they can't be repaired. And we have 5, we need 6. That's $360,000 to go out and buy those monitors.
Right.
So you have to know the business side of it too. And understand. For us, one of the things we did is we started in the last quarter of 2023 a transport service. We staff at 10 a.m. to 10 p.m., 6 days a week, primarily taking patients from hospitals to home, hospitals, skilled nursing facilities, hospital to hospital. It's BLS only, and it's a critical source of revenue for us. When we brought that service on, it was with 2 goals. We set financial goals for it, which they've achieved, and it was to increase our supervisor coverage from 12 hours a day to 16 hours a day, which we've done, and we gave our staff an across-the-board 15% pay raise. Based on the revenue from that service. So, the people that run that transport truck for us are incredibly important to this organization. Some of them do only that. Some of them do the emergency side and the transport side. So we expect the same of them, the same professional appearance, the same professional mannerisms, the way they're wearing the same shirts we are with their names, and going through other communities that aren't ours with the name on the side of the truck. We have high expectations of them, of how they perform and how they represent us. And they do a bang up job every day, and their job is to support the emergency side of what we do.
Mm-hmm.
So that's another critical revenue stream
Yeah.
for us also.
So that's kind of a another point that you bring up there is the non-emergency side. So I've seen services that have, they've gone from, hey, we don't do any nets, non-emergency transports, interfacilities, what have you, to we need money, we're doing everything that we can, and they've done nil in the way of staffing increase, or it's just, you guys have been sitting around too long. We're going to start pumping every transport we can in here. And then they burn out their crews because when they're not on an emergency, they're on a transport. And then, they're staying after their shift to get their paperwork done because they haven't had a chance to stop moving all day.
Right.
I think that balance is super, super important to find that balance to make sure you're covering your responsibilities by it's the end of the day, you have a contract, right? With the municipality. You're contracted to provide to them ALS ambulance coverage, right? So you're making good on that contract. But also doing the stuff on the back end, the transports, to help offset some of the costs and the difference in the revenue. But I think it's super important to do that responsibly. And I think from my perspective, it seems to be done that way.
Yeah, I think that responsibly is the key word there. I think again, with the opportunities I have to talk to municipal officials, one of the things I say is, you should be asking your ambulance service about non-emergency transports. How many are they doing? What are their criteria for taking them or not taking them? And all those kind of things. But if I ask a room full of EMS managers and say, if you could run your organization and not do non-emergency transports, would you? Their answer is going to be yes. If we
Yeah.
didn't have to do them, we wouldn't.
Yeah.
Right? So municipal leaders can only say so much about doing non-emergency transports with your emergency trucks if they're not going to fund them to fix the problem.
Correct. Yeah. No, I agree.
So, but there's a balance in there,
Hmm.
without a doubt.
Yeah.
So
Well,
it's
and
not an overnight process to change it.
yeah. And one of the other things you'd said earlier is that you're fully staffed. Uh, I guess I can attest to this. You guys put a pretty high um, premium, if you will, on education, training, advancing your skills, your credentialing, what have you. Um, to the point where I'm often on a double medic crew because you've had so many EMTs that are like, no, I'm going to go off to paramedic class, and you don't see that. That's a great problem to have where, even in the region that you're in, I think that's a unique problem to you and maybe one or two other services, but
And not only that, we paid for the paramedic class, or helped to at least.
yeah.
Yeah.
But and I think that's great. I'm a big fan of education and promoting and encouraging education for people. And I think it also helps you identify and keep good people, somebody I've said this to other service leaders, boards of directors, that, if you have a really good EMT and they want to go to paramedic class and that $5,000, 6,000, whatever it might be at the time, is the roadblock that they can't get past. If you can find that money for them, you have an employee for life,
Yeah. Well,
as
and
long
that's
as you
what we're
treat
trying
them
to get to.
correctly.
Yeah.
Yeah. And it's
In
people. Yeah.
one view, $5,000-6,000 is a lot of money. In another view, what's it cost to replace that person? What's it cost to replace their experience?
Hmm.
What's it cost to get them to come in and know your system and the way you operate? And
Yeah.
so you have the right person. If already know you have the right person, they want to
Yeah.
improve themselves.
Yeah.
All we ask is we ask for a couple things. That is that if there's opportunities for grants, there's one in Allegheny County, usually the Ambulance Association of Pennsylvania does one,
Mhm.
that they pursue those, and if they get those, we take that money off. But if they don't get any, as long as they pursue them, we'll pay the bill,
Yeah.
or what's left
Yeah.
of the bill, and then we ask them to stay for 2 years once they're done.
Seems perfectly reasonable.
Yeah. Of course, they're going to get the same raise they would have got and all those kind of things when they become paramedic, and
Yeah.
so
Well, and it's the other thing that I think a lot of people don't realize, though, the value of that EMT becoming a medic versus just bringing in a new medic. Like I'm familiar with half of your coverage area just from growing up and being in the fire department and half of it. But the Shaler and Aetna side is new to me. I'm often relying heavily on my partner for, hey, we got to go this way because the truck won't fit this way. I know the GPS says go that way, but it's a bad idea, go this way. Or,
thank God
you
for
know,
technology, right, and smart partners.
yeah. But so you're keeping that asset, that valuable asset, the knowledge that you don't get in EMT class, you don't get in paramedic class, you only get from time in the service. You're keeping that in it. Replacing that knowledge is often harder. I would say it's always going to be harder than you. If all you're looking for is a card with some numbers on it and a pulse, you can make that happen. But if you're
That's
looking
not
for
what we're looking
quality
for.
and knowledge,
I hope
that's the
that's
hard
very
part.
clear.
Yeah, no, that's I didn't mean to imply that you were. You're not. uh, every once in a while you let a goofball slip through, but
We
won't
have our
hold it
moments.
against you.
Eric, do you do a lot of hiring and firing?
No and no. We have certainly there have been some people that we've chosen not to continue with here. Let's call it that. But and certainly in the beginning, it was more. Right now, it's just not very often. I am not quick to fire anybody. We very much want to work with people, and if it gets us, things that we can do to educate or help. A lot of times people are having to work. Maybe it's not a work-related issue at all. We have an excellent EAP program that will support people through mental health issues, financial issues, legal issues. Also, we want to make sure what the issue is and try to help people through it. Our first answer is not to push people out the door except for the most egregious of circumstances. So, we hope that support is rewarded by, commitment to what we do and the way we do it, and it has been.
I was curious if you, in the interview process and stuff, had any, tricks or anything for finding people that are quality candidates. Because you'll have someone come in for an interview and be like, "Oh, this guy sounds great," and then you get them in your service for 2 weeks, and you're like, "What were we thinking?"
Well, that's right. I'm fooling them too. They think I'm a nice guy when it's over. um, a lot of times the people we're interviewing, we know. And if we don't know them, somebody here does. So, and a lot of times there are people that have been here doing clinical time on our trucks, and we know them far, far better. And then in those circumstances, the interview is a formality. We want to make sure we're on the same path, have the same goals, those kind of things, but we really already know them. I really can't think of a time that I've hired anybody in the last several years where we didn't have more than one person that knew them and knew them well and highly advocated for them coming here. So hiring blind, well, that's not happened in a while. So, we'll talk and have those conversations and so forth, but we don't do a real strenuous interview process. And we want to make sure they're kind of in line with the way we do things and understand how we do things. So it's not a surprise, and we move forward.
Yeah. I think something I would say to answer that, like how to kind of do that is you, you have to set these are the things we need you to do. These are the things that we will not accept to be done.
Mm-hmm.
Make those expectations clear in the interview. And if we're violating it, you do your progressive discipline. Too many people have their ego tied up in their hiring process. I've never understood that. You could be the biggest scumbag in the world and interview incredibly well. So, I think if people just, you're going to make some bad hires along the way, and you're going to have to correct it. And it sucks, but if you lay out the expectations, this is what I expect of you. And as long as you're doing these and not doing these, we're going to get along just fine. But if you start doing these and stop doing these, then we're going to part ways.
Yeah.
And then they fire themselves, they're not doing.
We have a thing called Star Care that is not, I didn't develop it. It's actually a tool of a guy by the name of Mike Tegman, who's kind of an EMS national thought leader. And it's 8 letters. Each letter for Star Care correlates to a belief of ours. And I call it our one-page policy manual. If you kind of look at this, and its talk is about, how you interact with your patients, how you interact with their families, how you treat their materials, how you interact with your fellow public safety professionals. If you were in front of your patient right now, could you tell them that you did the best job for them? Those kind of things. If you do that, if you follow those 8 points, doesn't matter what else the policy procedure manual says, it's going to make you operate in the way that we want to see. So we really try to make that simple. That's hanging in my office. It's hanging out in the crew quarters. It's hanging up in our Hampton station. And it, really is very simple. And many times, if there's a situation that didn't go as we hope, we'll come back and references against that. Doesn't set clinical guidelines, but it certainly sets expectations, behavioral guidelines for how we expect people to present themselves.
Yeah, I think I have a copy of it on my computer actually, but I do.
Plagiarism is your friend, no doubt about it.
I mean, you said it to me, so all right, we're good. But do you mind if I put it up there? Or?
Don't mind at all.
All right.
As long as it doesn't say Fior Star Care, sure.
It, I had to make it my own. It's for my own personal Star Care needs.
There you go.
I think I could put it up. I don't know. It's been acting funny lately. Not letting me share things. Huh. Well,
Do that in the post edit.
yeah, we'll put it up there. But no, I think if I remember correctly, the reason I have it is because, yep, when you hire people, they need to acknowledge that they've read and understand it, that it's not this, foreign concept that, once you've done something and you're in the, unfortunately, like a correction meeting or a disciplinary meeting or whatever you want to call it, a coaching session. It's
Coaching session. Yeah, that's right.
yeah, like it's hung on the wall in the station. We gave you a copy of it,
And we send an offer out to somebody, and we put those on everything in the email and attach what our benefits are and so forth. We attach a copy of Star Care, and they have to bring that back as part of signed as part of their intake documentation. Absolutely.
But I think you know, what you said there makes a lot of sense. If you use basically the principles that the organization holds valuable as your guiding posts, you're not going to find yourself in these disciplinary meetings, and it's not going to be disciplinary. It's going to be coaching, because it's, hey, we're right there. We just need to get you a little closer, and it's always going to be fixable. Uh, I think in EMS in general, I think if you operate by one rule, and that's put the patient first, everything else is fixable. We can figure out the rest. But if you're not putting your patients first, then I don't care how clean your truck is. I don't care how pressed and prim your uniform looks. The rest,
Truthfully, that's a cavalcade, right? If you're not taking care of your patient, your truck's probably not clean. Your uniform probably doesn't look good. You haven't checked your truck. Those things all go together. Rarely does somebody just keep a pristine truck and present themselves in really horrid fashion. It's a package.
usually, yeah.
Yeah, not always, but usually.
Yeah.
Yeah.
No, and you're right. But and come to think of it, some of the folks that I've met over my career, the ones I'm like, man, they are just terrible at their job. They're also the ones where their shirt's always half tucked or completely untucked. They just look like they rolled out of bed. Their boots are open. They won't wear the required pieces of the uniform. Like, I don't know.
Who are you talking about, Fior?
No, nobody there.
He's talking about me. I wear sneakers sometimes. He doesn't like that.
I actually don't have a problem with you wearing sneakers. I'm not going to wear sneakers because I don't want my foot to get crushed by somebody my size or larger.
Yeah, I like the way they work now. That's correct.
Yeah, but I mean, if you want to wear sneakers, by all means. I'm not paying your workers' comp premium, so I don't care. But I'm going to wear boots because of the safety factors that they provide. But you're more than welcome to wear sneakers. Now, if you start wearing highlighter green sneakers, I'm going to make fun of you for sure.
You should. I'd be upset if you didn't.
Good. But yeah, we forgot to ask you a really important question, Eric. I'm sorry to ask it so late. Do you prefer self-occluding or non-self-occluding IV catheters?
You know what I prefer? I don't care. One of the favorite things I get to do here, though, is go out and start an IV for a paramedic of ours that couldn't get it. That is my absolute favorite thing.
Yeah.
I'll tell you the time it happened, but every time it makes my day.
I could tell you on the rare occasions that I'm there on a daylight shift, I'm at the Shaler station. If we get a call that's an easier and the supervisor goes, and they happen to pull out in front of me, I yell at them, if you start doing all the cool fun stuff, you're doing the whole trip sheet. Don't take the fun away from me and then give me the paperwork.
Do you get to run a lot of calls being in your position, or is that something that you miss?
Well, no. So every Wednesday I'm the supervisor. That's by choice, and it's my favorite day of the week. I always say that. When I get to come in here and run calls, and as Fiora alluded to, I don't write trip sheets very often, and that's a good thing because, again, our people do a better job of it than I do. But I will never get away from being a clinical provider. It's too long that I've done it, and too much a part of who I am, without a doubt.
And that has to be valuable to being in a more administrative role, if you will, in EMS, is still knowing and understanding the clinical provider role within the organization. I'm sure that there are some services that are run amazingly that have their chief or principal director as an EMT or an AEMT, but that certainly takes a skill set. If you're not able to do the job, being able to tell people how to do the job that I don't possess. I need to be able to do it myself if I'm going to tell you how to do it. But
somebody in leadership chain has to have that clinical insight, no doubt about it.
Yeah, and I think that's important, and just as important as having the command physician on your board of directors providing that clinical insight from an outside and higher level, then um, I, it's it's super valuable that I think it helps because I'm certain there have been times or there will be times where you say, hey, we need this piece of clinical equipment that costs more than we'd like it to. Some of the boards like, well, it's a lot of money, but you have your doc that's like, yeah, but it's an amazing piece of equipment. It's going to save so many lives. And that kind of helps you get over those hurdles of we need to spend more than we wanted to spend. But
And just the natural price increase, like I said, whoever would have thunk the day, certainly not me, that a stretcher and a power load system and the warranty for it for 7 years cost you $80,000.
mm-hmm.
It's just, who would have thought it? But here we
Yeah.
are. And, if you want people to come work here, that's something that people look for,
Mm-hmm.
and it's just part of who we are now.
Yeah.
The last 2 ambulance we bought, we moved the power load system we had from an existing ambulance to one of the, instead of buying a new one. But, still works, still maintained,
Yeah.
still going to do the job.
Yeah.
But it was a way
I
to
mean,
save, 80 grand.
I mean, I've been doing this long enough that the power load is certainly a newer part of my career. And I can tell you, I certainly love them because it saves your back. I mean, I have days that I wake up sore, but the amount of people my age is kind of like in professional sports, you'd be old to be in the field. Now you can still do it because things like the power load systems and whatnot. But
Or stair chairs,
mm-hmm.
airbags for humans, all the,
Those are amazing. Eric or Aaron, have you seen those?
Mm-mm.
It's basically an airbag system. You get somebody that's heavier than you should be lifting safely, and it gets them up into a standing position safely, and nobody's getting hurt.
works
It's
very
pretty
well.
cool.
Yeah.
But
Eric, so we
yeah,
talked about like the constraints that a lot of EMS services have just with financially, and I think that forces a lot of people to be operating in a very like short term perspective of, okay, well, this is what we need right now because we got all these different problems that we got to deal with right now. So my question for you is, how do you plan for things long term for an EMS service, and like what does that look like? Discussions with the board and with your staff and stuff. Just because I think so few people in EMS management are in a position where they actually get to think about stuff like that because they're just so focused on putting out the fire.
So there's a guy who was on our board. Was not when I first came here. Was not on the board. He's the elected controller from Hampton Township. His name's Jerry Speakman, and I can remember very distinctly when he first came on the board. I'd been here about 6 months, and Jerry is laser focused on funding. Right, came in here and wanted to know why we had a 5th ambulance when we only run 3. And the contribution we gave you last year was a one-time thing. We're not doing anymore. But the good thing about Jerry and the amazing thing that we still rely on him to this day for a variety of things is he listens to reason and tries to understand. So that may be his initial statement and his initial goals, but he listens and will take that all into consideration to be moving forward. So now he's not even on the board anymore. He still is the electric controller in Hampton, but he's a retired guy who's willing to bring his expertise. And we're redoing. When I got here, the first 6 months I was here, we did a capital planning session or a long range planning session with my board. And one thing said, I knew that we had a serious fleet problem. We had a lot of problems with our ambulance. They're going to be aging out. They're keeping them too long. And I said, okay, we're going to design an ambulance. We're going to build an ambulance today. And we went through from the wheels up. How are we going to do that? So the board understands what decisions you're making. Why do all of our ambulances have an extended cab? What that cost? It wasn't hugely expensive. It was $3,000 per ambulance, I think, or something. But it's usually important to us because our students are up there. So when's the 2 most critical times we call for teaching? When you're responding and when you're coming back. Planning before you treat the patient and talk about what you did after you're done. The patients, the students in the back, they're not part of that conversation. So we built an ambulance. They came up and, wow, that's expensive. But they understand why it's expensive. They understand all the thought process that go into it. So Jerry took all that information and we went and said, okay, here's our plan for replacing ambulances, how we're going to finance them. One of the things that municipalities don't want to see is a huge increase in support to us on a given year. So we buy our ambulance, we finance them over 7 years. And they provide money to us that pays for those loans over the 7 years in a balanced fashion. And we're in the middle of that right now because of the incredible cost increases through the pandemic. We're now going back and looking at an ambulance that, our plan was we bought good quality ambulance. We're going to take those modules and remount them. instead of buying new. Every 7 years is what our plan is. And the ones we bought in 21 are coming up. We've got to get the orders in to get those delivered in early 28, here in the next 6 months or so. And the cost to do the remount has gone up by $100,000 over what we projected, but it's still $100,000 less than buying a new ambulance.
Right.
So we're doing that planning right now. We had those conversations last night. We had those conversations 3 months ago when we got together with the board to just talk about the beginning of the strategic planning process and updating those tables. And Jerry's intimately involved in that.
Mm.
So again, it comes back to having really quality people that are involved and focused on the organization. One of the people I'd like to talk about, actually, that I haven't, that's another game changer for us, is we have a medical director who's incredibly involved in our service. He's not just saying, "Hey, I'm a medical director, I'm going to sign your paperwork," but he's here. He's hanging out in the station. He's doing QA on charts. He's responding to calls, spending time here that is only to his own detriment. 2:00 in the morning, cardiac arrest at Sheets, and who walks through the door? Him.
He's come up behind me on some calls. I'm like, "Oh, when'd you get here?" I'm glad you're here.
You're right.
Wasn't expecting the help. Awesome.
Yeah. And he's a game changer for us. And many times now we have a new EMS fellow this year, and that happens every year. Somebody else who becomes intimately part of what we do. So certainly that's another benefit that we have that helps us with our education. Oh, and there's the other secret. That's my dog. This is really great. My wife just walked in while I'm doing an interview.
Excellent.
Bye. I was going to introduce you to the dog, but he's gone.
I saw him this morning. Very nice.
Yeah.
Very fluffy.
My wife works in the school. Today was her first day back. So the dog's back to coming to work with me today. Yeah.
About that.
Yep. Indeed.
But yeah, I think having a good medical director is a huge benefit. And I think more often than not, services have somebody that signs the paperwork. They don't care who it is. I think taking the time to, if you're looking for a medical director, taking the time to, I don't want to say interview, but do your research, get somebody that's going to be a benefit, not just a signature on a paper, So, I mean,
that decision, to add to that, when we made that decision not long after I got here, that was a crew decision. Many things that we do are crew-based. The design of the ambulance was crew-based. The medical director was crew-based. When we make any significant changes, it's not me. This doesn't affect me day to day. It's the crew. That's the people who are taking care of the patient, using the equipment. That's the people making those decisions. And then it's my job working with the board to find a way to pay for it.
Yeah. And I mean, I think that's a great way to do that. It'd be like me trying to pick out your office furniture. I'm not using it. It doesn't matter. So, but too often the person that uses the equipment the least is the one that does all of the research, planning, and implementation of the equipment that they're never going to use. So, having the providers that are going to be using that equipment intimately involved in the research and planning and implementation phases, I think huge for sure. So, well, hey, thank you so much for joining us today. Thank you for the consult. We've used a lot of your time. You definitely have given us some great things to think about. Some awesome knowledge. I'm sure we'll have to have you back, get some updates. But anything else you'd like to put out there? Anything you'd like to plug? Any final words for the audience here?
I guess the only thing I'd say is, I come back to the message of advocacy. We have to be our own strongest supporters. We really do. We don't believe in what we do, and we're not willing to talk about it, not willing to talk about the challenge we face, not willing to be transparent, then the support we don't get is what we deserve. We have to be out educating people. We have to be willing to show our books. We have to be willing to follow up, and prove what our value is to the community. Many people say, well, they should know. Well, no, they don't, because they don't do what we do.
Yeah.
And understand the incredible care that's provided and the level of it that happens in the back of an ambulance. So, it's our job to do that.
Yeah. One thing I'll put on top of that is, a lot of people still kind of think we're back in the 80s where we fly to the scene, we throw them on the stretcher, we fly to the hospital, and that's it. And just kind of, I don't know if I told you this or not, but I was recently visiting my family that lives over in Tanzania, and they had a lot of friends there that happened to be medical doctors in Tanzania. And I was like, hey, what would like the equivalent of what we do be in your country? They said several doctors, several different doctors.
Okay.
I said the general public obviously doesn't understand the training that we have to go through, the proficiency that we need to maintain in certain skills and all the skills, but the things that are actually going on and what it costs to just the equipment alone to provide this service that is so desperately needed. So,
Equipment, no matter how expensive that you go out and buy the best of the best, none of it matters if you don't have the right people operating it and making the decisions.
absolutely,
It's
absolutely.
the root of everything that makes you successful.
Yeah. Well, thank you again. It's been awesome talking with you. Um,
Deal.
well, like I said, I'm sure we'll have to have you back on if you do it. So,
I think we need to get
uh,
a panel together and we'll do a episode called Funny EMS Stories or something.
so there is a plan in place we're working through, and you might be the one to talk to offline how to make this happen.
I'm trying to think how
Um,
many I can share publicly. That's the problem.
yeah, right. We're still trying to figure out how to do like the voice modulation and the blurred face on the screen. Um,
Yeah.
but we want to do a like a roundtable type episode this year, or I guess at this point next year, up on the mountain. So
Oh, yeah. There you
we're
go.
going to figure out how to make that happen, even if it's having people come over to our cabin and make it happen. We're pretty intent on doing that. So
Sounds cool.
we'll see how it works. But again, thank you again for the consult, man. It was great talking to you. And for those of you watching and or listening, thank you for hanging out with us. And if you're interested in joining us, please reach out. Thanks for the consult at gmail.com.
Thanks, guys.